Make sure I can share my screen once again. And we'll go ahead and get started. We're nearing the home stretch here. All right, kind of move this out of the way. Okay. All right, we left off on slide 183. Before we get started, can I get confirmation, one, that you can hear me, and two, I'm wondering if anybody has any questions before we move on. Excellent. Great. All right. Let me see. Okay. We got uh, three talking about during the afternoon. I have more or less material depending on the group and also based on whether or not we've covered some issues associated with those groups already. And then we also have at the end some guidelines for what I would describe as culturally sensitive psychopharmacology with ethnic minority populations. So without any further ado, let's move on to talk about the Latino population. Um, just like I mentioned, for Asian Americans, this is a very diverse group composed by people who come from several different nationalities and ethnic groups. As I mentioned, they could be Native, Latin Americans, and have uh, Native ancestry, as well as European, African, Asian, Arab, and mixed for sure. As of 2010, numbers are growing, of course, as you guys heard me say yesterday. There's about 35 million Latinos in the US, and which comprise 12.5% of the US population. 3/5 of those 35 million, about 20 or 20.9 million, have Mexican ancestry, and by the numbers, those of Mexican ancestry are followed by Puerto Rican, Central American, South American, and Cuban. Most Latinos are Spanish speaking, though a significant number of native languages are spoken by immigrants and refugees, depending on where they're coming from. Portuguese is also spoken in Brazil, as you know, and um, it could be the primary language for some in this community. They also present with varied immigration patterns, some that represent economic migration, meaning, looking for a chance to have a better life or economic improvements, jobs, et cetera, et cetera. There's also been war, terrorism, and crime refugees in the 1980s, quite a bit in early 1990s associated with the civil wars in Central America and some communist regimes in Guatemala, Salvador, Nicaragua, etc., as well as more recently crime refugees from all sorts of places in Central America that are escaping crime-related violence. There's also a good number of affluent sociopolitical exiles, specifically from Cuba, but also from other places that where, several decades back, the more affluent portions of the population were able to leave the country before either a military takeover or more stringent, um, like a communist government was able to take over and take away their economic means. This group is sort of unified by religious tradition, though not quite. There's a lot of there's an increasing number of uh, Protestant and other religions practiced in Latin America. It used to be Catholicism was a primary religion of the region, but not so much anymore. And also adherence to religious practices vary wildly, population by population. I want to share this little, with regards to labels, this little cartoon. It was from a syndicated cartoon known as Baldo. I don't even think it's published anymore, but I'll give you a second to read it. So, again, with regards to labeling, you may find groups of Latin Americans that describe themselves as Latinos or Latinx. You may find that they would rather use descriptors such as Mexican American or Chicano or Cuban, simply Cuban Americans. Puerto Rican Americans, South Americans, you name it. There's a great degree, great levels of variability with regards to self identification. We'll talk about epidemiology like we have for Asian Americans. Diabetes is twice as prevalent in Latinos compared to the general population. Hypertension is very common, less likely than Blacks and whites to continue taking antihypertensive medications as prescribed. And some of those issues that I mentioned before with our Filipino case study may come into play with Latinos. Again, it's a silent killer. There's likely to be less symptoms. Um, Economic pressures can also play a part as to into whether people believe in taking the medications as prescribed, or prioritizing this medication versus other medications that may be seen as more important. And and obviously this can create a significant risk when it comes to cardiovascular disease. Overweight and obesity are also common, and so you put that all together in the perspective from in terms of metabolic syndrome can be quite significant. In some Latino groups, combined overweight and obesity are um, again, overweight and obesity are quite common. Obesity rates among Mexican Americans are higher than the obesity rates of the general population. And likewise, the um, uh, obesity rate in Mexico has actually surpassed the obesity rate in the United States. Um, the incidence of cervical cancer in Latino women is doable, a double, not doable, sorry, that of non-Latino European American women. You could, potentially consider some risk factors, including, decreased rate of vaccination against HPV, potentially a decreased rate of predominantly preventative care, such as regular Pap smears or well woman exams. That could be problematic. Um, let's see what else. From an epidemiology perspective, much higher rates of unintentional injuries. Also, for both Latino males and actually for just Latinos in general, homicide is in the top 10. Uh, Top 10 number of or rates of death. Um, Latino women have higher incidence of cancer versus heart disease, and also experience higher rates of chronic liver disease compared to all the other groups. Okay. HIV infection has also crept up in the Latino population in the previous years, with African American women, specifically, and Latino women, shown increasing numbers of new infections. So if you look at, let's see, this was 2012 diagnosis of HIV infection. 40 new diagnoses, 47% were African American. Um, something like, um, let's see, 21% are Hispanic Latino, and 28% are white. So those are the three largest groups affected by HIV infections. And in contrast, what you see on the right is the percentage of the population of the U.S. that they represent. So whereas again, African American women, African Americans in general represent 47% of the new HIV infections. They only represent 12% of the general population, and again, 17% of the U.S. population is Hispanic, but the new infection rates are 21%. Eddie says condom use would likely help reduce HIV spread. And yes, absolutely. But there are probably some cultural and some religious issues that may be associated with lower use of preventative sex safe sex practices. Let's see, I think I've already told you about all of that. Um, Suicide is in the top 10 list of causes of death for Latinos. And I think everything else has already been mentioned, so we are going to leave it at that. It's important to highlight that depression and diabetes often co-occur in the Latino population. And one study at least has shown that depression may be the best predictor of hospitalization associated with complications of diabetes or diabetes treatment. Um, both of those together, both conditions together, increase the risk of chronic heart disease, of course, and the presence of depression may reduce compliance with the medical regimen associated with diabetes treatment, to include more failures at weight control, dietary restrictions, and exercise programs. So it's really critical ease out the presence of depression, for patients who are diabetic. Um, for I don't know why that keeps coming up. Prevalence rates of mental illness are equivalent to Caucasians. There isn't really a significant increase or decrease in numbers in terms of most psychological or psychiatric conditions. But we do see an increased risk of suicide and suicide attempts for Latina adolescents, specifically. In one study, they were mentioned to be twice as likely to have attempted suicide, and numbers as high as 1 in 5 Latinas under the age of 17 were thought to have experienced a suicidal crisis. Generally, as a group, they underutilize mental health services, and just like the two other groups that we have discussed before, they are much more likely to present to uh, their primary care or other medical providers, and may seek help from other traditional healers versus seeking quote unquote mental health treatment. Sorry, I didn't update the dates here, but we saw in the beginning of the class the rates of no insurance versus government or private insurance are pretty low or high, pretty low for this population, definitely higher rates of uninsured or public insurance compared to other segments of the population. Um, you might see in this population that there is a tendency to blend mental and physical health. And again, seeking help for physical symptoms may be more appropriate and palatable, and also potentially more accessible because of lack of culturally competent mental health providers in the community. You do see practices, especially more traditional families, and depending on, both nationality and education levels, the use of spiritistas or spiritual guides, curanderos or santeros, which are all traditional healers. Um, Santeros and curanderos are much more commonly seen in the Caribbean population, but also, don't be surprised if you see or hear of them being used in other parts of, and people who come from other parts of Latin America. Latinos may see prayer and herbal remedies as treatments. In fact, way long time ago, when I was after my bachelor's degree, I was in the Peace Corps. I served in a rural area of Ecuador, and it was often the case that a child who was experiencing a diarrheal disease in that area of the world would be taken to a spiritual healer. And the combination of the practice of prayer and herbal remedies was very common. And so my piece, from a cultural sensitive perspective, because I was a health worker, was to try to encourage also education and use of clean water and some other, some more scientifically based diarrheal treatments, in addition to some of those folk therapies that they were engaging in. Janelle says, it is important to note that the folk healer listed routinely referred to medical physical health. I mean, they referring out to medical physical health providers. Yes, and in many Latino communities in the United States, you see farmacias or pharmacies where these individuals practice, and they very commonly work with other medical providers within the population and refer back and forth. And, I'm glad you pointed that out. It is really important to note that they may not be seeking those treatments exclusively, but they also may be consulting with several, engaging in several forms of care. And so for you as a medical psychologist or a prescribing psychologist, it would be important to assess for the use of traditional versus non-traditional healing practices. Um, they may have you may see different impressions of the severity of illness depending on whether the interview is conducted in English or Spanish. In fact, some epidemiological studies, such as a survey of Puerto Ricans using the diagnostic interview schedule, found that in interpretation had to be modified in the interpretations of some items concerning psychotic experiences because of the cultural tendency toward beliefs in spirits, visions of voices, and presentiments that exaggerated or provided a biased view, making it seem like a psychotic disorder was present. And this was different if there seemed to be some difference in whether the interview was conducted in English versus Spanish, and or obviously with culturally competent interviewers. All right. As far as culturally or cultural-related syndromes, there's one very specific syndrome mentioned in the DSM and also in ICD-10 that you should know about, and that is a syndrome known as ataque de nervios, also known as the Puerto Rican syndrome. It's not only seen in Puerto Rican populations, but it could be, you could find some use of that terminology. Ataque de nervios literally means an attack of nerves, and is demonstrated in certain situations, also almost even prescribed and socially acceptable. Bouts of uncontrollable shouting, crying, trembling, and tearing of clothes that is triggered by a stressful event involving family. So things like the death of a close relative, an injury, accident, or a tragic incident involving a family member. Again, it's culturally approved and is somewhat expected in certain circumstances, such as in a funeral or after receiving some tragic news. But in some cases it could be quite problematic. And I remember when I was working with in my practicum, my supervisor mentioning a case that she had treated of a serviceman who was of Puerto Rican origin, and how consumed, how disturbed he was with the fact that he had experienced an attack of the nervios in front of his children. So it's almost like a panic attack. I guess that would be the better way to describe it. But again, there are some circumscribed set of symptoms that make it specific, very culturally relevant. With regards to somatic complaints, I wanted to bring this study to your awareness. This is a little bit dated, but I think I think it's the 2005. I think again, it provides very important cultural information, and I thought it valuable to talk about from that perspective. So what you see is a study of almost 1,000 patients with major depressive disorder in 7 Latin American countries, and you see some of the countries flags on the left here. Not really important. Are you getting a little lag? So I'm getting, repeated notices that my internet is a little bit unstable. I apologize for that. I'm gonna take a moment. I hope I don't mess up anything, and see if I can connect to a more stable one. Okay, can you guys hear me okay? Have I lost you?
I can hear you, doctor.
Okay, is the feedback still there?
Yes, it's still there.
Oh, goodness. I'm not sure why that is. I'm going to remove all electronics from the proximity of the computer just in case. Sometimes that creates feedback. Is it any better now?
Yeah, we don't see any announcement on a screen you share.
Okay. All right. I'll keep going. If it gets really bad, let me know, and I'll go get my Wi-Fi extender or whatever that may be, and see if we do any better after a break. Okay, so again, not really important to know which countries, although you see some of the flags listed in front of you. What's important to see is the moderate or the relative prevalence of somatic symptoms in patients who presented with major depressive disorder. So what you see is the white bars representing no symptoms. The light green is a little, the purplish, bluish bar is moderate, and the red is intense, and the orange mean unbearable. So just, we don't have to explain the graph. What I want to highlight is the relative prevalence of some somatic symptoms associated with MDD. If you look at the first bar with regards to muscle pain, just about 80% of patients with MDD presented with muscle pain. About 45 to 50% presented with abdominal pain, somewhere like 65 to 70% presented with back pain or lumbar pain, 60% with chest pain, almost 80% with headaches, 60% with joint pain, and 80% with neck pain. Now, none of these cases, according to the report, in none of those cases, those symptoms, those pain symptoms, were attributed to another medical condition. They were just manifestations of the major depressive disorder. So I think this graph, more than anything, highlights the significant impact or a significant prevalence of somatic complaints associated with psychological disorders. Okay, As far as antipsychotics, or yeah, treatment with different psychotropics, we're going to talk a little bit about what to do, what to avoid, what to use, and what to avoid. Um, Antipsychotics, with regards to antipsychotics, it's important to highlight that schizophrenia is overdiagnosed, and again, in some cases, it may be related to overinterpretation of symptoms, such as the belief in spirits, the belief in and um, ghost and other old supernatural type of experiences as uh, diagnostic or representing psychotic symptomatology. Um, Indeed, bipolar may be underdiagnosed, and I wonder if anybody has a guess as to some cultural factors that may contribute to the underdiagnosis of bipolar disorder. Yes, stereotypes of fiery Latinos, otherwise described as histrionic, loud, with rapid speech, and intense type of communication styles. Carmen says perceived as being high energy. Yeah, so there may be difficulty differentiating what a manic episode looks like based on stereotypes about being fiery, again, easily agitated, easily very high energy, et cetera, et cetera, et cetera. As far as treatment is concerned, Latinos may require daily doses of antipsychotics that are roughly 30% less than those of Caucasians. And remember, keeping in mind the relative risk of metabolic syndrome is probably a good idea to both start low and try to maintain patients at the lowest dose possible, because we can certainly see those risks increasing with higher doses, especially of the newer medications such as Zyprexa. Uh, no difference in the prevalence of tardive dyskinesia that we can observe. With antidepressants, there seem to be mostly psychopharmaco or pharmacodynamic differences due to no perceived differences in CYP2D6 activity. But the general rule is they may respond to lower doses of TCAs. They may also present with a greater concerns about side effects. And again, keep in mind when you talk about side effects of medications, I want you to keep all of this in mind, right? So what are the side effects of antidepressant medications, both SSRIs and TCAs? Can present initially with GI distress, which is already, present in about 50% of cases of major depression. Headaches and increasing headaches, which again is already present in almost 80% of cases of depression, and general, fatigue, malaise, decreased energy, that sort of thing. So it is important to highlight that, that greater presentation of side effects may be both not real, but a significant pharmacodynamic effect um, in with regards to this population, or it may just be an exacerbation of the cultural tendency to view the disorder and perceive the disorder as a somatic complaint. I mentioned before the Paxil trials that we discussed with regards to the Asian American population. Hispanics had the lowest rate of full response in a duloxetine trial or study raised, quote unquote, which was in that sub study defined as African American and Hispanic, was considered to be not predictive of treatment outcome. And I've already, shared with you both the article and my thoughts about the use of race. Or self-defined race characteristics in research studies. With regards to stimulant medication, we see equal prevalence of ADHD in Latin American countries. However, the estimates with regards to treatment is that only 0 to 7% of children with ADHD receive stimulant medication compared to over 60% in the United States. And there again, there may be some culturally relevant factors associated with that, such as potentially reluctance to engage in pharmacotherapy with children. Also, I do believe some cultural expectations about whether children should be high energy, low energy, should be rambunctious and um, um, active, et cetera, that may play a part into those treatment rates that are drastically significant. I talked a little bit before about placebo effects. They tend to Hispanics tend to have, or Latinos tend to have a higher rate of placebo response compared to other populations. And this is from a study of a sample and Colombia versus the United States. This is 2008. And the study was about predicting duloxetine response. They had very small minority samples. Uh, I'm sorry, take that back. No, this isn't duloxetine study. This is the imipramine study. So it's an older study, but I think it highlights the placebo effect and how it may play a role into patient response or lack of response, perhaps. Um, what we see is so this is the response rate is described as a 50% or greater reduction in HAM-D scores, or the Hamilton Depression scores, Hamilton Depression Scale scores, and you see a 90% response rate with imipramine in Colombia and a 50% response rate with placebo. Whereas in the United States, you see a less than 60% response rate with imipramine and roughly a 10% placebo response. Even in the difference of response to imipramine, you could potentially make a case for the placebo effect, having an impact right there. Jason says, as a child specialist, I have definitely noticed anecdotally a higher level of hesitation to use pharmacotherapy, especially in the younger children when they're typically being diagnosed with ADHD. Yeah, interesting. Like I said, I do think that there is some reluctance to using medications, and there may be some cultural beliefs associated with medicating children um, as well. Let's see. Okay, I think that's all I want to say about that. With regards to the placebo, one thing that I would do want to note with regards to the placebo effects is that there is a significant amount of something to consider potentially is whether or not the a relationship and instilling hope and creating a therapeutic trusting relationship between us and the patient can potentially enhance that placebo effect in a way that would be therapeutically positive for the patient. And so, it goes back to what I said yesterday about the same medication prescribed by a different provider, maybe it wasn't yesterday, but maybe it was this morning, can't recall, same medication prescribed by a different provider in a different therapeutic setting might have a different effect on the patient as an individual based on that therapeutic relationship. And so I do believe that in this population and in others, I think in clinically, generally in a clinical perspective, we can ethically capitalize on the placebo effect to the benefit of the patient. All right, I'm going to run through a brief case example. This is a textbook example, so there are going to be pieces of information I may not know about, but I think it's useful in illustrating some of the cultural considerations that you may have with a patient in this ethnic group. So Mrs. Gonzalez is a Latino Mexico-born female, so she's Mexican American, age 56 years. She's a widow and a recent immigrant, and I don't know exactly how long. She lives with her married daughter and speaks only Spanish. Her daughter is her interpreter. At her first primary care clinic visit, Mrs. Gonzalez complained of severe weakness, back pain, joint pain, and joint pain, all which she had been experiencing for several months. Other somatic complaints included abdominal pain, flatulence, headaches, palpitations, and dizziness. Um, I'm going to give you some information that's not on this slide, and then ask you again to, make some, ask some questions, or provide some thoughts as to how to deal with this with the case of Mrs. Gonzalez. Mrs. Gonzalez's medical history included a previous diagnosis of mild hypertension. She had been prescribed a low-dose diuretic that she had not taken for several months. Her family history included diabetes mellitus and hypertension in a brother and sister. Physical examination showed nothing abnormal except for slight obesity and mild hypertension, which was um, uh, measured as 145/90. Lab exams, including EKG, CBC, liver function test, a thyroid panel, were all normal. Okay, so any thoughts as to, things you'd want to know, things you'd want to assess if you were, a behavioral health consultant working in this primary care setting, some ideas or thoughts about what you would offer both the patient and her clinician? Question from Angela. Is it okay that daughter is the interpreter? Do we want a non-biased interpreter? Ideally, we would. I think more and more we've come to find out that there's a lot of factors that may play a part into using a family member as the interpreter. They may not be as familiar, especially if they're second generation, third generation, they not may be familiar with all the nuances of the language. They may also censor some of the information that the individual is providing out of shame or embarrassment, or potentially because they think it's not relevant, and they might minimize the tales that they consider to be not important but could be important. So in most medical settings, the use of a medical interpreter is highly encouraged, unless you really don't have any other option. Eddie says glucose. Glucose was fine. It wasn't described as one of the things that were measured but all of her lab assessments were within the normal limits. She needs a full medical workup, which was completed. She's been cleared out from medical. Not really. Again, her hypertension seems to be uncontrolled, but other than that, no significant medical issues were identified. How much does diet lead to other somatic complaints? Potentially, especially if she has uncontrolled hypertension. Is her diet contributing to the feeling of abdominal pain, headaches, and even, things like flatulence, of course, and even some of the other symptoms? Janelle says, I would want to know who she interacts with outside of her family and how long she has been a widow. Also, the nature of her marriage. Yeah, good points. I mean, she is now, she's a recent immigrant and living with her daughter. And because she is not an English speaking, um, she's not English speaking, I'm assuming her level of independence and her support system outside of the family may be quite limited. Um, Kirsten says, how long has she been living with her daughter? When did she immigrate and why? How long has she been a widow? Any family back home? Yeah, all good, very good questions. Brady says he would consider bereavement and adjustment, including recent migration issues. Was there a cardiac workup? Yes, EKG was found to be normal. Um, Are grandchildren or extended family in the picture? Good questions. What meds is she taking? The only medication that she had been prescribed was a diuretic, which we heard she had not been taken consistently. Eddie says diet may be different due to composition of products used to prepare food, unless in the Southwest there are not many. Carne said yes. Yeah, and who knows? We don't have that information. When is she experiencing the symptoms all the time, or are there situations that exacerbate her concern? And Janelle says we may be dealing with an adjustment disorder. Yes, very good inputs, good thoughts. So let's delve a little bit further. I think everything that you guys said, you may bringing up good questions, making good points that should be considered in a case like this. So we have the PCP again. She's being seen by her primary care provider. The PCP prescribes a low dose ACE inhibitor and asks the patient to return in 2 months. At the next visit, the daughter indicated her mother's pain has continued and was unresponsive to acetaminophen or Tylenol. In addition, she noted that her mother slept poorly and did not want to leave the house because of her physical problems. So she's now becoming housebound. The PCP reassured the patient with interpretation from the daughter. Um, Question from Rebecca, is she not compliant with diuretic? Will she take an antidepressant? Good question. Do we believe that she has depression, and it's very possible that she does? And so would she take an antidepressant is a very good question. A few days later, the PCP receives an urgent call from Mrs. Gonzalez's family indicating she was in crisis, agitated, not sleeping, sobbing, eating little, and complaining of multiple pains. The doctor suspected a psychiatric problem and asked the nurse at the clinic to assist the patient in an emergency visit. So at this point, we have more than physical complaints, which were the ones listed on the slide, weakness, back pain, joint pain. Now we have a patient who is agitated, crying uncontrollably, experiencing sleep difficulties, sobbing, eating very little, and complaining of multiple pains. So at this point, my guess, from everything that I've read in your comments, but also I would imagine we would have a high suspicion for depression at this point. Yes. She would be a good candidate for an antidepressant and possibly a benzo, do you mean, for a short period of time? Um, So she does speak with the clinic's nurse, who assesses her to have symptoms of depression, as well as anxiety. We do see some significant agitation. The physician does prescribe a benzodiazepine for sleep and refer the patient to a clinic nearby. The family, however, disagrees with the recommendation and makes the statement that the symptoms are not in her head, so take the patient to another PCP. In this case, although that new PCP also suspects depression, his referral fails because the bilingual therapist or psychiatrist in the area does not accept is not accepting patients. Um, so I highlight this case because there's a lot of there's a lot of issues that could accept access to care in this individual, including the patient and the family's perception that the symptoms are not in her head. What do you make of that, and how do you guys handle how would you handle a situation in which a patient is telling you, "I'm not crazy. This is not in my head." And what could be the role of medication versus counseling in a patient like this? Danelle says mental distress can cause physical problems. I would agree with the family. She's not crazy. However, she has suffered a great deal of loss. So you'd want to normalize that people in her situation could experience symptoms that are much more psychologically related than potentially physically related. Carmen says I would want to provide a menu of intervention options. Okay, say more. What sort of interventions would you put on that menu? Heather says you want to explain psychotherapeutic approaches, psychotherapy prescriptions, activities in her community like church. Yes, and some ways to expand her support system and potentially to facilitate her adaptation to this new environment and potentially her new life stage. I mean, she is a recent widow, and so there may be issues associated with that. Kirsten says, I deal with that a lot. I explain to the patient that there's nothing wrong with you, but you have a lot of stress to deal with, and counseling can help get some of it out and not stuff it down while the PCP works on what's going on. Yeah, so you'd want to validate that the somatic presentation is not, it's not a manifestation that she's crazy or the symptoms are in her head. You want to explain mind and body connections and help the patient understand that stress can exacerbate medical problems and manifest itself in very different ways. Rebecca says, depending on where she lives, there may be a large Latino community, so there may be some ways to help her integrate and increase her social network and social support system. And some agreement from Nina with regards to psychoeducation about depression. Absolutely. And given that she's not an English speaker, what sort of, culturally competent or culturally relevant resources do you think you would bring to bear on a case like this? Say there may be Spanish speaking church services, resources to support her or for us to help her. Depends on how religious she is. There may be a church in the area from which she can get additional support. And there's also keep in mind that there's a lot of, the Latino population is large and ever growing. So there may be some, although we did find some limitations with a bilingual provider in the area, there may be some other resources for counseling, or even peer counselors or other extended sources of support groups perhaps that may be available in her native language. And if not, as we talked about the use of interpreters, it might be useful to refer to consider the use of an interpreter besides her daughter, because that would be a good place for us to be for her to be able to potentially gain some potentially be able to express herself more freely about issues of adjustment or adaptation to being under the care of under the dependent on her daughter with regards to her living arrangements, her daughter being her only interpreter, meaning her interpreter meaning potentially her only connection to the outside world, and that sort of thing, change in status, etc. We have a recommendation for Meetup, good idea for social activities and support. And I appreciate you sharing the opportunity to, potentially look specifically for activities that might be available for Spanish speakers. Does she believe she is suffering due to living beyond her husband or some other things she has done? That's a really good question. And again, there may be some things those may be questions that she might be hesitant to explore in the presence of her daughter, because there's going to be a certain amount of respect and dignity that she would want to maintain. And so, again, bringing to bear either a bilingual therapist or and the use of an interpreter might be quite helpful. All right. Great participation. The only other thing that I would add is that um, Spanish, is a commonly spoken language, of course, in the United States, especially in certain areas. But there are some resources that I'll share with you at the end of the, excuse me, at the end of the class that might help you to assess the symptoms in people who are depressive symptoms and other psychological distress in people who are non-English speaking. So, they talk in this case example, we talked about the using the Prime D, I think. Prime MD as a way to elicit anxiety and depression symptoms. There are, translated screenings that you could use in your practice that of mainstream measures that could be used in other languages. And also, if you don't know this, there's I'm not sure about Hippocrates, but I'm pretty sure Medscape has educational materials in other languages available about certain drugs, certain diseases and conditions, and that may be something you want to look into if you serve a clientele of folks who are non-English speaking. All right, with that, let's do questions number 9 and number 10, and this will be a good point. After that, it'll be a good point to stop to take our next break. All right, I think we have a good number of you who have already responded. So unless anybody wants to do a last minute response, we'll go ahead and end the poll and share the results. So as you could see, first question, ataque de nervios and Hawa Bayong or fire sickness are examples of what were described as culture-related syndromes. So 57% of you are correct, and you would not be incorrect in saying that they're also anxiety or affective disorder related syndromes. I think to some extent that is true, but the best answer out of all the ones that are present here would be culture-related syndromes. Um, with regards to the second question, compared to the general population in Latino groups, diabetes appears to be um, more prevalent, is what 90% of you endorse, and that is the correct answer. So, not necessarily any more or less prevalent in women or men, but significantly more prevalent in the population in the Latino population as a whole, compared to other populations. So, good job. Thanks for the practice. And with that, let's go ahead and take a, 10-minute break. I got 1700 or 5 o'clock my time, so it must be 2 o'clock in California, and I'll see you in 10 minutes. There we go. Okay. All right. Uh, We are moving on in our next section to talk about African Americans, and then lastly, we'll be talking about Native Americans. And as I mentioned before, finally, we'll be sharing some guidelines about the culturally competent treatment of minority populations in general. So African Americans, as we have learned, have experienced a great and significant amount of health disparity in the United States. They represent also a very diverse group, 34.3 million or 12.2% of the US population, um, with some of that, a large part of that number being descendants of African slaves, some Caribbean African, new or newer immigrants from African countries. And at least by the 2010 estimates, at least 2 million, more or less 2 million, that were considered mixed race individuals. There's also some very wide cultural differences, urban versus rural, south versus north, Christian versus others, and there may be significant levels of variability in terms of, cultural perspectives based on based on that background. Um, I just want to introduce this topic by talking about the controversy that was brought up back in 2004, 2005 really, when the U.S. Food and Drug Administration approved the drug Vital, which at the point was marketed as the first quote unquote race-specific drug. The idea being that it was targeted to be the treatment of choice or the first line treatment of congestive heart failure in Black patients. Its approval was based on trials that were conducted between 2001 and 2004, what was described as the African American Heart Failure trial, which was an all Black clinical trial. And the findings indicated that there was a 39% reduction in first hospitalization rates for heart failure, and a 43% increase in survival rates, which is not insignificant. So the findings, were touted again as proof that we could individualize therapy, including potentially from a quote unquote race specific perspective. The problem was that after approval, like many other things, post-marketing studies and post-marketing experience or prescribing experience brings a deeper level of clarity to what may actually be ignored or potentially overlooked in the pre-marketing trials. A deeper look at the research showed that in the clinical trials, that this All Black trial that I mentioned before, of this drug, which by the way is a combination of true generic hard drugs. At the time, they were essentially combining two drugs that were already available in the generic form to create a new a new and improved and expensive new formulation, involved only self-described African Americans. So there was no genetic or biological markers of quote unquote racial identity that were used in this marketing or pre-marketing trials. And also, the findings were that the drug was not useful for all blacks, and actually could be very, very useful for some whites. In other words, its utility as the first, again, race-based drug may not have been defined by race at all. So again, a complex issue that may be more controversial than it may seem. Okay, we'll talk about epidemiology. We do know already and have talked about it before that there's some significant differences with regards to prevalence of hypertension. And also one thing that you may not have heard before, hopefully you have, is that African Americans have a higher incidence of sickle cell anemia. Overweight and obesity rates are higher than the general population, with numbers as high as 65% of men and 56.5% of women who are overweight or obese. Cardiovascular death rate for men and women far exceeds that of the majority population. And again, you could argue that it may have to do with health disparities, or distrust of the system, or lack of access, the inability or resistance to engage in preventative care, and or again, that treatment of potentially untreated hypertension going on too far or too long. Diabetes rates are higher than, again, the general population. And also the incidence of complications, including lower limb amputations and end-stage renal disease, is pretty significant compared to the general population at large. Some other findings, actually, I do have some notes I want to share with you. Um, okay. I think I've already mentioned that in terms of death rates, homicide ranks in the top 10 for African Americans. Septicemia, African American males specifically, and septicemia is also in the top 10 for this population. Okay. We do see that women are more likely to be infected with HIV, and as I mentioned before, as a group, African Americans bear the biggest burden of new infections and have for the last several years, with heterosexual transmission being the most common form of transmission for this population. About 10% of males suffer from a mild form of G6PD deficiency, which we talked about yesterday. Um, Cancer death rates are about 35% higher, 35% higher than in the general population. We also see a high incidence of lactose intolerance in African Americans. And also there's some indication that certain diseases like prostate and breast cancer may progress more rapidly. More rapidly, I mean. One thing to say about G6PD deficiency is that individuals with this deficiency may exhibit anemia, in some cases very severe cases of anemia, especially when an infection or exposure to certain medications or chemicals, or a significant acute stress. Okay, with regards to HIV diagnosis, again, 42%, this is a recent statistic from the CDC's. 42% were among adult and adolescent Black African Americans, Blacks or African Americans. 31% were among Black or African American men, and 11% were among Black African American women. 31% and 11% of those total infections. What am I showing you here? I think again, increasing rates, you could see the line on top is Black or African American in terms of new diagnosis among adults and adolescents. Um, and um, um, and again, you could see some numbers for yourselves that we already discussed. Like I said, the majority of new cases, in fact, in some statistic, 88% of women were infected through heterosexual contact and not drug use or any other means of infection. There seems to be some indication that there are higher prevalence rates of some mental disorders, but those tend to be obliterated when SES is controlled. So, not accounting or accounting for the impact of poverty, which is more common in the African American population as a whole. The rates of mental illness are the same as those in the general population. So, as far as the poverty rates, African Americans are twice as likely to be living under the poverty guidelines or poverty rate in the United States, with 24% of the population considered to be in the poorest of the poor, compared to 12.3% of the general population. However, SES does not account for the problem of underutilization. And again, there's probably a lot of other reasons, including distrust of the system. If you recall from our discussion yesterday, the Tuskegee syphilis experiment and other breaches of trust with the African American community have created a significant problem with regards to underutilization. They do double the rates of utilization of inpatient care as it relates to mental illness specifically. And it's hard to say whether or not this is because they present with higher levels of severity or higher levels of acuity that require hospitalization, or because there is let's say, a language or a communication or a perception of severity, primarily by Caucasian or other groups of mental health providers, with regards to the need to hospitalize a patient, meaning, as the assessment of risk for both personal and interpersonal violence that could lead to hospitalization. More likely, African Americans are more likely to use an emergency room for mental health problems as opposed to, again, maintaining services either from a primary care physician or a mental health provider. There are also some significant predictors of depression in African American women, including life stress, physical health problems, and internalized racism, and age. So the highest risk group with regards to symptoms of depression in African American women is those women who are between the ages of 20 and 29. Um, okay. As I mentioned before, there is a problem with underutilization of mental health services, and as a group, Blacks tend to use more inpatient services and less outpatient services. You may see a tendency to rely more on social supports and informal systems of care, such as prayer, folk remedies, or no treatment at all. They tend to be prescribed antipsychotics more, and as we discussed in the beginning of the class yesterday, more significantly for conditions that are not as severe as psychosis or schizophrenia. And in some cases, we do see prescriptions of older antipsychotics and at dosages that are higher and more often depot version of the drugs, which make an assumption or make a statement about compliance, quote unquote, or adherence, despite the fact that they may show greater sensitivity to the side effects of this medication. So just, something to be very mindful of. Um, we do have some information that would point to African Americans responding or metabolizing some medications differently, including psychotropic drugs, immunosuppressants, antihypertensives, cardiovascular drugs, and antiretroviral medications. For example, Dirks et al. Found that oral bioavailability of specific immunosuppressants in African Americans was 20 to 50% lower than that of non-African Americans. So differently doesn't necessarily mean less or more. I suppose it depends on the class of medication, but we do see some good examples of, again, response and metabolic rates being different in this population. We did find or Glacier found that African Americans were 1.8 times more likely, so almost twice as likely to develop tardive dyskinesia than Caucasians in the 4-year follow-up period. And this is, again, this could be related to the use of older psychotropic medications or neuroleptic medications being more common, as well as potentially being used at higher doses. Uh, that may be medically necessary or that may be well tolerated by this population. So definitely recommend greater caution in prescription of antipsychotics for African Americans based on that finding. With regards to antidepressants, they may require lower doses, may be more prone to develop toxic side effects, possibly due to poor metabolizers in the 2D6, higher and therefore developing higher TCA plasma levels, at least in 2 studies. And if you go back through your slides, you could see that there's a significant number. I think it was something like 33% of African Americans that may be poor metabolizers on the 2D6 system. So definitely something to be aware of. For benzodiazepines, one interesting finding in the literature is that African Americans may be less likely to be diagnosed with anxiety, period. Also may be less likely to be prescribed benzodiazepines. And, one question that may come up is whether there's a chicken and egg situation here. Are they prescribed less benzodiazepines because they are also less likely to be diagnosed with anxiety? Or is there another factor going on, such as potentially the perception by some providers that African Americans may be drug seeking or may experience more problems with addiction, and so therefore potentially prescribing practices that are more cautious toward scheduled or controlled substances. They do appear to be more sensitive to the effects. And we can predict a greater sensitivity to 2C19 drugs, as anywhere from 15 to 25% of African Americans are poor metabolizers. But this has not been demonstrated clinically, so this may or may not be true, and it may depend on the drug. But there is, at least some sense that this could be at play. Um, all right. As far as pharmacodynamic differences, um, you it'd be important to know that we do see some differences in the treatment of with the treatment of African Americans with propranolol, and that it seems to be less effective with in treating hypertension, in treating African Americans with hypertension versus Caucasians, but there's not enough information to say whether or not it would have similar effects on its use with performance anxiety or intermittent explosive disorder. But just be mindful of that because it is possible you may have to try other options. By the way, Asians require lower doses and experience greater effects on blood pressure and heart rate with propranolol as a finding. Um, okay. I think that's all I have. I don't have a slide on this, but I think it's important to highlight from a cultural perspective, again, issues of distrust. We talked about them in the context of the little radio snippet that you guys heard yesterday. Issues of what constitute a family or a family circle in the African American community. Many single parent homes. That many multi-generational families living under the same roof, meaning mother, grandma, or children, mother or father, and mother and father, and grandparents, aunts or uncles, and other extended family supports, providing support for the raising of children. There's also non-blood relatives that may be considered to be just as important or just as critical um, in terms of engaging and understanding the family dynamics, including godmothers or godfathers, or neighbors, friends, and church neighbors and friends, and church parents that are common in this community and in this population. And it would be a mistake to ignore the relative influence of those individuals when treating an African American, a member of the African American community, especially a child. So, really important things to keep in mind. Again, I don't mean to, beat a dead horse, but definitely want to emphasize working with, rapport building and trust building, and, working to come up with sensitive and competent formulation. Um, that may be that may be relevant to building those relationships and establishing trust, and and being able to work with this population in a culturally sensitive way. How about multiple sexual partners with differing kids? Is there any research to suggest what is causing this? Do you mean I'm not sure what you mean. Do you mean um, a mother who may have children by different with different parents? I mean, different men. Okay, I not that I have seen, and I have to admit I haven't really delved into that specifically. But again, there are issues of poverty. There are issues of um, uh, you know. Dynamics that are interestingly unique to this population. I mentioned before the higher presence of depression, or higher rates of depression in women between the age of 20 and 29. We know about higher death rates, homicide rates, and accidental deaths of men in the African American community, as well as you know, over represented in incarceration rates. And so that I think we do in certain communities, and I don't want to generalize to all African American communities, but in certain communities, we do see issues, social issues associated with those things, relatively low rates of marriage, or long-term relationships, and that sort of thing. And again, there are many on different sources of stress that could manifest in psychological distress and illness. Um, okay. All right, we're ready for the next poll question. So let's go ahead and do that. All right, I think we got the majority of you responding, so we'll go ahead and close the poll and start sharing. All right, so the question was, African American rates of new diagnosis of HIV were out of proportion to the relative numbers in the population between 2008 and 2012, which is true, and that's what 94% of you endorsed. If we go back to slide 189 as one way that we highlighted it, but the most important way that we highlighted it, although it's in future slides as well, you could see that as a relative percentage of the US population, African Americans represent 12%, versus their numbers in terms of new diagnosis of HIV are 47%. So that's a pretty out of proportion number with regards to the population. Okay, all right. Good job. Thank you for participating. And now, okay, we're going to move on to speak to issues associated with the Native Americans. And before I do, I want to give credit to a previous classmate or a previous aligned graduate, Dr. Anthony Trinquita, who is also a previous Air Force psychologist, but currently in the U.S. Public Service and serving in the Indian Health Service as a prescribing psychologist for the last maybe 6, 7 years or something along those lines. A lot of this materials were provided by him with his permission to be used. I have to admit a significant lack of clinical experience with this population. So really appreciated his inputs. And we're going to start actually by having you listen to a little snippet that may help you understand some of the issues with access to care and other issues that may be experienced by a population. So I'm going to briefly stop sharing the screen so I can get to the right website. And please let me know if you have any difficulty hearing what I'm about to play for you.
Support for NPR and the following message come from Target. Hit the play button below to meet Ray Phillips, co-founder of Soap Socks, and hear how Target cultivates relationships with companies like Ray's that are majority owned and operated by people of color.
The life expectancy of Native Americans in some states is 20 years shorter than the national average. 20 years. There may be many factors in this, and here's one. About a quarter of Native Americans report experiencing discrimination when they go to a doctor or a health clinic. That's a finding of a poll by NPR, the Robert Wood Johnson Foundation, and the Harvard T.H. Chan School of Public Health. Here's Eric Whitney of Montana Public Radio.
Margaret Moss knows the Indian Health Service, or IHS, well. She's a member of the Hidatsa tribe, and she's both received IHS care and worked as an IHS nurse. She now teaches at the University of Buffalo. Moss says people who get health care from IHS know two things.
You better get sick by June because there won't be any more money, or it's life and limb only. Those are the things that would be authorized.
The federal government promised to provide American Indians health care when they signed treaties giving up nearly all of their land. But in reality, Congress sets the Indian Health Service budget, and it comes out to about $1,300 per person. That's compared to nearly $7,000 per person for health care in the federal prison system. The result is that there are few IHS hospitals and clinics, and they're pretty limited in what they can do, says Moss.
That is the idea out there in Indian country, is that I'm not even going to try because it's not going to happen.
IHS refers a lot of patients out into the private sector for care that it can't provide, but it only has money to pay for about half of them. Moss says that means that a lot of Native Americans just learn to live with health conditions that most Americans get treated.
They say they're fine, but they're not. And I call that tolerated illness.
Even when Native Americans have good private insurance, many say discrimination can keep them from seeing doctors or getting the care they need. Anna Whiting Sorrell is a member of and works for the Confederated Salish and Kootenai tribes in Montana. She has good insurance through her job, but when she needed a hernia operation a few years ago, she kept falling through the cracks.
I got referrals to a gastroenterologist. Somehow that got lost. I never got where I needed to go. The tests got done. The tests are getting lost.
Sorrell was finally able to get surgery, but only after complications from her hernia landed her in the emergency room fairly recently. Private insurance paid for most of the operation, and the IHS contributed to the rest. But when it was time to schedule follow-up appointments after her surgery, Sorrell thinks using IHS marked her as an undesirable patient.
It got denied. My follow-up got denied.
Sorrell says nobody from IHS or the hospital called to let her know. She felt like she was falling through the cracks again, and says at this point in her life, it hit particularly hard.
I was 57 years old. My mom died at 57.
Sorrell eventually got her follow-up appointments and is finally starting to feel healed. She's resolved to take good care of herself in what feels like bonus years she's been given. For NPR News, I'm Eric Whitney in Missoula, Montana.
And now, more from
Right. Okay. Just want to confirm. It sounds like some of you at least were able to hear. Okay. Hopefully, everybody got the gist of what was discussed in that little radio snippet. Thoughts, reactions. And by the way, questions as to whether anybody who's currently in the audience has worked in the Indian Health Service or has worked with Native communities and what their observations are. Yes, very sad indeed. Was anybody surprised to hear that the relative funding of Indian Health Services is about a quarter of the funding for federal prisoners? hmm Yep. Okay. Well, yeah, definitely not. Najib says, but I think it applies to a lot of people. Yeah, there's a lot of, there's a lot of issues associated with access to care and certainly with health disparities that are unique and not unique to this population, but certainly a way to introduce some of the difficulties that might be faced by these communities. Kirsten says, I don't work with a lot with Native communities, but there is a stereotype based on presentation. I've had a couple of professionals think the patient was developmentally delayed of some sort when they were just soft-spoken and differential, not complaining. Oh my goodness, how sad. Um, I wish I had chased paid staff better. I agree. And if you're interested in prescribing, this is an area where you could have a lot of impact. And potential, if you have student loans, get loan forgiveness. So I have to, I have to put in a plug for that because that is certainly an area of need that you could potentially affect. Okay, of course, it goes without saying, but making broad statements about the interaction between American Indians, Alaska Natives, and First Nations people and the healthcare system would, um, and specifically the mental health care system would be stupid. There's just, so much diversity in this population, and there's so many different systems of care and tribes that any kind of generalization is, very, very difficult. As you can see, there are currently 566 federally recognized tribes in the United States, representing 6.2 million American Indian and Alaska Native people, and more than 200 languages spoken, according to the Office of Minority Health. Department of Health and Human Services Office of Minority Health. And of course, this doesn't include tribes which are not recognized by states, or that may be recognized by states rather, but not federally, or in some cases not recognized at all. There's also 630 recognized First Nations governments or bands in Canada. Some of them may have some relationship with Native tribes in the United States, but not all. Actually, most not. They represent 700,000 people. And approximately 22% of Native Americans live on reservations in the US, whereas in Canada, 56%, or the majority of First Nations people, actually live in reserves. So once again, it is important to highlight that having any amount of expertise with such a diverse group of people may be dangerous. So cultural humility and a willingness to learn and apply knowledge may be important, especially as it relates to the comment that Kirsten made, assuming that stereotypes based on their presentation would fit the individual client in your office. According to the 2010 census, the poverty rate for American Indians and Alaska Natives in specific areas was significantly higher than the general population. So for example, in South Dakota, in Rapid City, South Dakota, the poverty rate for Native Americans is 51%. And in Anchorage, Alaska, it was 16%. In many, this poverty and socioeconomic status varies a great deal by tribe, and also by whether or not tribes have opened themselves to things like casinos or other sources of income that may be affecting their population as a whole. 28% of American Indians spoke other languages at home, other languages other than English. Um, most people in this population have a high school degree, and some, not a great many, but some have a bachelor's degree. And you could see the relative proportion to whites or non-Hispanic whites is pretty significant. So in general, the population has a lower levels of literacy and in high school and college education. 26% over is the national average with regards to living below the poverty line. I've already mentioned that the national average for all populations is somewhere around 12%. So this is, quite a significant number. 39% of American Indian, Alaska Native women report a history of intimate partner violence, and those rates are the highest in the nation by ethnic groups. So definitely some significant socioeconomic issues. Excuse me. Median family income lower than non-Hispanic whites. Mentioned that as far as private insurance versus insured or uninsured, public insurance or uninsured, again, significant differences. If we go back to the numbers that were presented yesterday, you could see that there as well. And in this data that we present here, in general, life expectancy 4 to 6 years lower than the national average. You heard in the radio report that in some cases it could be up to 20 years lower than the national average. And also we see an increased infant mortality rate. With regards to the disease burden or epidemiological factors, what you see in front of you is higher rates of diabetes, heart disease, cancer, TB, substance misuse, approximately twice the national average. Fetal alcohol spectrum disorder rates in some areas are 3 to 4 times higher than the national average. For example, Alaska being one of those places. Suicide and suicide rates are in the Alaska Native tribes are the highest in the world, which is pretty concerning. Again, high rates of accidental death, violence, including rate of violent victimizations that are 2.5 times the national average, as well as cases of hepatitis and HIV. Speaking of HIV, again, if we look at new diagnosis by race and ethnicity, the rate of diagnosis of HIV in American Indian, Alaska Native is 20.2%. And again, if we look at the rates in comparison to the relative numbers in the population, completely out of proportion. Women will have higher incidence of cancer than heart disease in this group. Risk of unintentional injuries is twice as high as every other group. And lowest risk of heart disease of all groups. So I guess that would be one silver lining. And as I mentioned before, American Indian, Alaska Natives is one of only 2 groups with chronic liver disease in the top 10 with regards to death risk, with Latino women being the other group. American Indian women show a risk of diabetes that is 3 times as high as every other group. So once again, with regards to risk of hyperlipidemia and metabolic syndrome and other complications of psychotropic medication use. American Indian women, Latina women are, definitely, and African American women are definitely populations, women and men really, populations that you want to look out for. And then you see in front of you, homicide is also in the top 10 causes of death. Okay. With regards to suicide, again, a very concerning issue for this community. Relative risk are listed in front of you with American Indian, Alaska Native men in the first column, non-Hispanic white men in the middle column, and American Indian, Alaska Native men, non-Hispanic white men ratio in the last column. So the most significant number to look at, or population or subset of the population to look at in this graph is the Alaska Native and American Indian population between the ages of 15 to 24 years old, who are almost twice as likely to die by suicide as the non-Hispanic white men population. For women, very critical risk, because again, what we see is that women in general have lower rates of suicide, but the risk for American Indian, Alaska Native women is 3.6 times higher especially in the age group of 15 to 24 years old, compared to the risk for non-Hispanic white women, and that is quite remarkable. For adolescents, again, we see twice and almost 3 times as much or much higher rates in adolescent females versus non-Hispanic white females. But again, total and for males specifically, almost twice as much the risk. So things to bear in mind, especially when you're talking about suicide risk assessments, is consider that some populations have experienced multiple suicide clusters, meaning a suicide contagion effect, or multiple deaths by suicides, especially in the teenage or adolescent population. Causes could be very varied, including poverty, substance abuse, multiple traumas, including intergenerational or transgenerational trauma, or historical trauma, sexual violence, influence of gangs in some communities, lack of connection to traditional cultural roots, kind of feeling a poor fit in their tribal community, as well as being feeling like a poor fit in the mainstream community. And so, of course, risk assessment, especially for adolescents, can be quite tricky because it doesn't map to standard predictive risk factors that we may see in the general population. So one of the questions that we should consider asking an American Native or, American Indian or Alaska Native person is, and I think it's potentially something we should consider asking a lot of other people, is if they're related to or know someone who has attempted or died by suicide. Because again, there is such a thing as a suicide contagion that has been spreading through different communities. There may be some genetic polymorphisms at play. There's scarcity of research. Of course, again, this population is not very well studied, and again, it may be too diverse to be able to draw any kind of significant generalizations. But there's potentially polymorphisms that have to do with with alcohol dehydrogenase as well as aldehyde dehydrogenase, but studies are contradictory, and whether they make this population more susceptible or less susceptible to the effects of alcohol has not been well determined. There is some data that certain medications, the clearance may be less than 1/3, or about 1/3 less than that of other ethnic groups. The standard mantra of start low and go slow certainly applies with this population. Lithium and antipsychotic medications are sometimes cited as requiring lower doses for Native American communities or Native American individuals. And the same may be said with regards to benzodiazepines, specifically with regards to Alaska Natives. Questionable data again with regards to genetic polymorphisms on 2D6 and 2C19. And again, I think a complicating factor is that the populations are definitely too diverse to be able to draw any significant generalizations. All right. So once again, because of the diversity of this population, the message about their beliefs with regards to utilization of mental health or about mental illness is problematic. The attitudes can range from full acceptance and endorsement of mental health models to suspicion and outright mistrust, especially for those communities who have suffered abuse, really, there's no other way to call it, from health professionals. We do see that in research, higher dropout rates are common. There are no cultural concepts of distress related to Native Americans that are listed in DSM-4. So as you know, almost every other population, I've been able to describe a culture related syndrome, but there are none listed in DSM-5 for Native Americans. And previously the DSM-4 TR had listed ghost sickness, but it's no longer there. Many native languages do not contain words for anxious or depressed. And so the relative, again, acceptance or knowledge or sensitivity to mental health issues may vary from tribe to tribe. It is true that studies have shown that more Native people seek the services of traditional healers, anywhere from 1/3 to 1/2, than biomedical services or Western types of healthcare. Perhaps for some of the reasons that were mentioned in the radio snippet, meaning access. And availability, as well as competence, cultural competence, and the way that those services are funded, but also because of their belief systems, for sure. Okay. All right. I am thinking. Okay. We have a few more slides to cover with regards to this population. I think if you don't mind, just so I can clear my throat and stand up and stretch, let's take a shorter break this time, and hopefully we can run through the rest of the slide set and our final comments for the class, and still get out a little bit early tonight, so you can start or enjoy the rest of your weekend. So I'm going to stop here on slide 227, and it's 2 minutes after the hour, and we'll come back in 5.
Doctor, before people go to the break, I'll appreciate if they take the attendance tool.
Sure, let's go ahead and do that. All right, let's take a 5-minute break. So I'll see you guys 10 minutes after the hour. Close to the end here. So, like I said, we just have a few more slides to go through with regards to the Native American population, and then some closing thoughts and comments. The opportunity for questions, and we should be good to go. So with this population, just like with some of the other populations we have discussed, we definitely have to think about health behaviors that may impact psychopharmacology, such as practice of ceremonies that involve fasting and abstaining from water for days at a time. Why would that be a problem? You know, think about the patient who may be taking lithium, where hydration is important, um, um, being underhydrated or dehydrated could potentially cause toxicity or inappropriate drug levels. Ceremonies such as the Inipi or sweat lodge involve the use of intense heat. Potentially psychoactive substances such as those used in the sacred pipe, which include multiple plants, and that may or may not have interaction effects, not just with each other, but potentially with the psychotropic medications that you could be prescribing. Remember that peyote, which is most definitely a psychoactive substance, is legal in the use of the Native American church, and may have significant interaction with stimulant medications. Plant and herbal medicines are the most common types of traditional therapies used in this community. And if you haven't yet, I think it would be a good idea to become familiar with the National Natural Database, um, that allows you or gives you the ability. I'm going to copy it into the chat box. Gives you the ability to do to check on the interaction between some herbal remedies and some drug medications, or some psychotropic drugs. The reason I say some is because it's not all inclusive, and so your ability to check on some of those reactions may be limited. And as you can see in front of you, the most common statement about safety in this natural medicines comprehensive database is there is insufficient reliable information available about the safety of. So you may still have questions about interactions and adverse reactions that may go unanswered. And so, proceed with caution. Some other practices or health behaviors that you want to be aware of are the use of things like bitterroot, which interacts with digoxin, which is an antiarrhythmic use for chronic heart failure or chronic heart disease. Sweetgrass counteracts antacids and antiacids and H2 blockers like Tagamet, and PPIs or proton pump inhibitors like omeprazole, and may have some interactions with CNS suppressants, with additive effects, as well as with MAOIs and St. John's wort. Both do, it's described as reserpine-like effects, and, just in case you don't know what it is, it means lowered blood pressure to CNS depression. So they could potentially be dangerous. And then you see some other potential effects with yerba santa. You could have an interaction with lithium due to the diuretic properties. And again, anything that will dehydrate you will increase your blood serum levels of lithium, which could potentially bring about toxicity. Chokecherry, not chokeberry, provides inhibition of CYP3A4, and just so you remember how many medications are processed through CYP3A4, about 60% percent of all pharmaceuticals, not just psychotropic medications, but all pharmaceuticals. And so, chronic use of choke cherry can definitely impact the ability of the liver to metabolize other medications. Sage can contribute to hypoglycemia. It may interact with CNS depressants, having additive effects and possibly lowering the seizure threshold. So, if it goes without saying that you definitely want to have a good communication, good and open communication with your patient if you're seeing a Native American or Alaska Native individual. But they may, also consider that they may not trust you enough to share with you the potential cultural rituals or Native health behaviors that might impact your prescriptive choices. And so you have to be, really careful, and you want to make sure that you provide education to patients about the potential issues associated with these things. There's a lot of reasons why there could be mistrust of the system, just like with African Americans, the mainstream society, the larger population, going back to the colonization of this land, has gone. Has gone out of their way to create again systems of distrust and difficulties for the population. You all heard about controversy with regards to cultural appropriation, including names of sporting teams, and now, or more recently, appropriation of ceremonial life with, issues with, spas and, healing businesses and enterprises recreating some of the traditional Native ceremonies sometimes to their detriment. And if you want to look up, if you haven't heard of it, the Sedona Sweat Lodge that's is an enlightening example of that. Remember that, in the past, it was illegal for Native Americans to practice their culture and spiritual practices. For example, the ghost dance. And this all changed with the American Indian Religious Freedom Act of 1978. But for, several people Native people who are alive now, and for several generations before, their practices, their culture, their history were suppressed. And, of course, you've heard of stories of forced boarding for Native American children so that they could be mainstreamed or taught in the mainstream society, as well as, a lot of other cases of historical trauma. So, once again, it's important to remember that, in many cases, our current patients may be only 1 or 2 generations away from forcible placement in boarding schools, or with foster families of non-Native families, again, for mainstreaming purposes, and, which were detrimental to the culture. And he says, I grew up on Indian School Road in Phoenix. Tell me more about that, if you don't mind. What was that experience like? The end result of these factors, of course, is a huge mistrust of outsiders in relation to discussing cultural practices. And again, that might make your patient very hesitant to share that they engage in, the smoking of ritual pipes or sacred pipes, or that they may be using peyote, or that they may be using, some of the many herbal and plants that we discussed, and how would that impact potentially the interactions with psychotropics that you may be prescribing. Thank you for sharing. So you're saying my understanding is that is referring to indoctrination into white culture, and young Native Americans were not allowed to use Native languages or Native dress or Native, religious practices, et cetera, et cetera, et cetera. So yeah, absolutely. Definitely a bit before your time, I'm sure. But again, it may be one, some of our patients may be just a couple of generations removed. It could be their grandparents or their parents, depending on their age, that grew up in some of within those cultural conditions. Again, research has been purposely limited in its scope and release. And as you probably heard, there were many tribes that experienced abuse from researchers who had ulterior motives and presented data related to the tribes that they were studying in a way that was not approved by the tribe beforehand, leading to, again, additional ruptures and trust and the ability to really use that data appropriately. Okay. So one thing you need to know is that because of the Indian Self-Determination and Education Assistance Act, which, obviously is subsequent to the boarding school practices, 54% of mental health programs and 84% of alcohol and substance abuse programs are run by the tribe. And so, for providers, non-American Indian providers who wish to work in this setting, it does take a bit to be able to integrate, become knowledgeable, and understand the rules and procedures and practices of working within this community. There's, I think for younger Native Americans, the experience of walking into worlds, with more of the younger generations describing the idea of living and working in blended cultural communities, where traditional cultural beliefs are strong in many communities, but also they have ties to Christianity and other religious practices that are more mainstream. Again, their manner of dress, their style, their language and communication may be more mainstreamed, despite some adherence to traditional practices, and as well as potentially increased focus on community. But also experiencing increased pressure to use, technology, go outside of the tribe to go to school, or increase their chances of economic success by leaving their communities. And of course, this can lead to conflicts within the community and on an individual level regarding the right way to do things. And I do recall, sharing with Dr. Tranquita when I was supervising his practicum, how he experienced difficulty with a patient who was a single parent, living living with her mother, and while raising a child, and the pressures that person felt about walking the two worlds, trying to remain true to tradition and practices of child rearing and parenting and religion, spirituality associated with her tribal identity, but also at the same time functioning as a person in the mainstream society, and trying to influence or teach her daughter ways that would make her potentially more successful in the mainstream society. So as you can tell, very complicated, very complex, and it's difficult to do justice to the information that you would need to be able to be a competent provider for this population. All right. We're going to talk a little bit about mental illness around the world. I give you the opportunity to read the article on whether antidepressants depress Japan. And I know you've been saving this for a while. But I wonder if you have any comments or thoughts about the article and your impression about what it means to, what it means in the context of a global economy and a global society, and what influences such as those economic influence by the pharmaceutical companies may be playing a part into, what were thought to be more traditional beliefs about mental illness. Okay, you can't have forgotten it already. Anybody has any comments or thoughts? Okay. Heather says it's interesting that Eli Lilly decided not to market Prozac there, but then a Japanese company came up with their own medicine. Indeed. Eddie says we did depress Japan, or we depressed Japan. Yes, creating a new terminology, a new disease, per se, so that we could provide a new treatment. Certainly speaks to the influence, again, the marketing and economic pressures. Mm-hmm. And it does, I think the article does a pretty good job of mentioning how, perhaps updating old beliefs and reducing stigma about mental illness and what true depression is may be useful for the community as a whole, especially as you consider the impact of sort of ignoring those factors. But there are certainly issues associated with that may be problematic. Here's another article, and you guys can continue to comment as you see fit. From 2010, Ethan Waters is a writer, I think also for the New York Times, although I'm not for sure. And they talk about Western, he talks about Western expressions of mental illness, such as depression, PTSD, and anorexia, and how much they have spread across the cultures with, as he says, the speed of contagious diseases. Because of the influence of pharmaceutical companies, because of the influence of American media, movies, television, et cetera, and also because of what he describes as well-intentioned Western-trained mental health providers who may rush in to provide assistance during war and natural disasters, and delivering psychological first aid as opposed to allowing for the native and inherent sources within the population that allow people to heal from tragedy, including hurricanes, tsunamis, and other natural disasters. And interesting, he points out, when asked to name the sources of mental illness, and this is again back in 2010, but relatively a relatively new phenomenon as opposed to 20, 30, 40 years ago. People from a variety of cultures are increasingly mentioning things like a chemical imbalance, a brain disease, or genetic inherited factors, which is much more a Western style or conceptualization of mental illness than any that I have shared with you, based on traditional values of this populations. Eddie says, I don't think he knows how psychological first aid works. Yeah, potentially tell, say, maybe say more about that. I did read, I wish I had it in front of me. I don't think I do. I did read an interesting quote from an individual in the health system. So let's say the national health system in one of the African countries, I wish I could be more specific, that experienced a natural disaster as some time. And they talked about how psychological first aid was perceived compared to the natural and again, native sources of healing, such as spending time outside, being close to, being in touch with family, going for walks, using music and then prayer or rituals, and that sort of thing. So I think it's about pointing out the differences in worldview and conceptualization of illness, and also what to do about them, that he is arguing for or against, I suppose. Heather says, I have the book Crazy Like Us, which is a very interesting read on America's take and influence on cultures around the world. Interesting. I need to write that one down. Eddie says, I don't think the symptoms people have experiences for years before we had a nosological system. And just because we have studied and tried to improve our understanding does not mean that it was made up just for pharmaceutical companies. That's true. I think that there's, again, to some level, an argument could be made that generally better understanding of mental illness and its development and its etiological factors could be potentially something that is not a bad thing per se. Okay, good points. Thank you. All right. Okay, so I want to finish with a quote from Weston and Brown. It's a little bit of older quote, but I think it's important to highlight as we try to wrap up this subject or this topic, that to understand a patient's experience of illness, a physician, in this case a psychologist or provider, must attempt to enter the patient's world, to understand the patient's beliefs about what is wrong, why it happened, and what should be done. And that kind of goes back to the idea of understanding their conceptualization. Arthur Kleinman came up with 8 culture-specific questions that might help us to get there with patients that are of a different culture or have a different cultural background or worldview compared to us as a therapist, including things like, what do you call your problem? What has costed? Excuse me, how severe is it? What do you fear most about it? What kind of treatment do you think you should receive? This is a way of meeting the patient where they're at, and I think those questions could be a useful guide, again, for assessing patients of different culture. Just want to emphasize that prescribing is more than just knowing what medications are useful for what conditions and under what circumstances. Medications have meaning for the giver and the receiver. For us, and for other prescribers, it may be I feel useful, I feel needed, I feel helpful. I have the ability to ease the patient's suffering, and that is internally and potentially externally reinforcing. For the receiver, it may mean I am crazy, I've lost control, I don't know how to handle my life. I think the doctor thinks that there's something wrong with me, and or potentially it could have a different meaning altogether. And it's really important to understand that dynamic. Understand that the collaborative model is not always welcome. You want to ensure that medications are not substitutes for failure to understand or even listen to the patient or recognize their experience. We've already talked about considering beliefs about the potency and the perception of what side effects mean, and understand that a medication that is at odds with traditional beliefs will worsen compliance. We want to consider the influence of family on compliance, whether, you know, the husband, sister, daughter, parent is supportive and believes in psychotropic medication or the use of the medical model of disease versus a different model. Uh, Remember that in Western cultures, the disease causality is centered within the individual with things like genetics, lifestyle, diet, use of substances, exercise, and developmental history. But traditionally, in Eastern and other cultures, the disease causality was placed outside of the individual. You know, such as those imbalances or disharmony between opposing forces in nature, and so on. We've already talked about some of this, but you know, it is important to highlight that all major multicultural groups will use traditional healers and methods to different degrees and depending on levels of acculturation. Oftentimes, those traditional healers are the first specialists sought out in times of mental illness in general, but certainly specifically mental illness. And failure of, and on our part, to respect the role or discount the role of traditional healers, or discounting the role of traditional healers may compromise treatment adherence and obviously success. And I'd like to use this cartoon to sort of highlight the idea of a compromise or the ability to walk the two worlds. Again, I think just to emphasize that the idea that we need to be able to talk about traditional healing resources and to respect the client's desire to use them if needed. So things that you need to know for, again, from a culturally relevant or culturally competent perspective, you want to assess level of acculturation, including language use, birthplace, migration history, generation status, ethnic identity, attitudes toward family, gender roles in the family, especially if your client happens to be a woman who is generally speaking much more likely to be not the privileged gender in most traditional societies, and social interactions within the social culture. We've already covered some of this assessment issues, talking about traditional healers, diet, use of herbal medicines and substances, habits such as use of alcohol, nicotine, and substances. Also, don't assume that all label groups share the same identity. You know, for African Americans, the experience and the cultural beliefs of Haitian Americans versus British Africans or Brazilian Africans, Jamaicans, or other Caribbean African populations may be completely different. Likewise with Hispanics or Latinos, remember that the person may not identify with their label, or even with American-born counterparts. And I've had many conversations with folks in which I try to assess, you know, their identity, and you know, oftentimes will say things like, "I see myself as much more like my white friends than as my Latino parents or grandparents," just as an example. We already talked about some examples of helpful questions in a previous slide, but I think those are others that may be important for you to consider. One thing to keep in mind is that being culturally competent and culturally humble requires us to analyze our own biases and stereotypes, and hopefully you had the opportunity to think about some of those as we were discussing in very broad terms, and potentially with even some stereotypical information, what you know about these different cultures and groups. You want to be patient with differences in narrative styles and accommodate time constraints that may be, you know, may be difficult in one setting, but also may be difficult for the client to understand. So be willing to extend the interview time, be willing to consider including other parties in the interview, including, again, parents of an adult patient, or children, adult children of, of an older person. Um, okay, let's see. So make sure that you do include cultural factors in your decision to prescribe, things that we mentioned before. Make sure you are providing appropriate, culturally relevant education to patients about the risk, benefits, side effects, and alternatives to medication, as well as counseling, of course, because you'll have the option to do both. Hopefully, for those of you who are going to be able to prescribe at some point in your future, or at least be consultants. Be sure to think about the choice of medication based on medical history, concurrent medications, diet, and food supplements. In general, you might start patients on lower doses than recommended prescribing guidelines, but you also want to monitor the patient, proceed slowly, and increase the dose as tolerated, and also understand that you might end up using the standard dose for an individual that you might have predicted would be, potentially a poor metabolizer, somebody who would respond to a lower dose, because at the end of the day, you want to make sure to treat appropriately. Consider medications that allow for therapeutic drug monitoring, especially if you have concerns about metabolizing status. You also, with populations, especially those that fall below the poverty level or the poverty guidelines, you want to consider cost and availability of the medications. It does you no good, or it would do you no good to provide drug samples of the latest and newest and most expensive medication when their insurance may not cover it and they may not have the ability to come back and maintain that medication regimen. And so, maybe using some older medications might be useful in that sense. I mentioned I was leaving you with some ideas about using assessment tools that could be used in other languages. You see assessments of PTSD, anxiety, depression, and this is not an exhaustive list. I'm sure there are many more available. So just, make sure you take the time and try to find a language appropriate version of a standardized assessment so that you're not, kind of shooting in the dark with regards to, being able to ascertain both the condition and the severity of condition that you might be treating. And I mentioned some patient education resources that I think would be useful, including MedConsult, Hippocrates. Hippocrates does have patient education. Click on Spanish when available. It's not available with all the drugs, but it might be available with some of the ones that you could be recommending. I mentioned the Natural Database. And again, there's in MD Consult and also within NIH description about depression, anxiety, and other mental illnesses that may be available in other languages. Okay. I think that's it. Before we finish, though, I do want to I do want to give you access to the last of the poll questions. So Aiden, if you don't mind, could you go ahead and post that? All right. I think we're very close to most people haven't responded, so we're going to go ahead and close the poll. And let's share and read the results. So you were asked to be part of a panel that sets up the formulary of covered medications for an HMO or health management organization or managed care organization. In considering which medication should be covered in order to contain costs, you suggest that. And obviously, as with other questions, the best option, the best answer is what we're looking for. Most of you, 75%, chose answer C, which essentially says that therapeutic substitution, that is the practice of switching to a cheaper drug of the same class, may be clinically risky for ethnic minorities that may have polymorphisms that lead to poor metabolism of certain drugs, which is the correct answer. We didn't specifically address it, but I think you got the gist of it from our discussion both yesterday and today. I would agree partially with with answer number one. There are no significant efficacy differences between SSRIs or between SSRIs and SNRIs or NDRIs. Therefore, inclusion in the formulary should be purely based on cause. That is an acceptable answer, but not the best answer as it relates to our topic. And then the other two are not consistent with information that we have talked about, and or potentially with the use of HMOs or managed care. Okay. That is it, folks. Just want to make sure you don't forget the inter-meeting questions for day 2 that have been posted on Moodle. I want to thank you all for your attention and participation. It's been fun to teach, and you guys are great at responding to questions and topics. And of course, if you have any questions, feel free to reach out to me. I will log into my Alliant account here and there in the next few weeks, but more reliably, I will be reading emails on my Yahoo account. So I wish you luck through the end of the program, and all have a good night.
For those of you who are still here, there is a between week assignment for the coming week to do.